Thank you. I've been asked to speak about this compound. This is CC292, formerly called Alvilla 292. This is I have in my laboratory, anyone who says that this is a BTK inhibitor, I get all on top of them because none of these inhibitors are specific for the enzyme. And I think this is a small molecule chemotherapy-like drug that can inhibit BTK. And BTK, of course, is prominent. I don't need to go through this slide, but importantly, it may affect the receptor signaling through a number of pathways, Ig, chemokine, as well as toll-like receptors. This is 292, and it's an oral bioavailable compound, has irreversible, supposedly covalent binding to the C481, very similar to the type of activity that you have with ibrutinib. The inhibition with BTK kinase activity is quite robust with an IC50 of less than 0.5 nanomolar, which compares comparable with ibrutinib. This has high cross-reactive, other types of proteins actually can inhibit, but limited cross-reactivity with Tec family kinases as well as ITK, although it has an IC50 of around 36 nanomolar, and has some cross-reactivity. It's low with Lin kinase and SYK. It's non-existent at greater than 10,000 nanomolar. So it does appear to be selectively targeting BTK and a few other enzymes with less activity against some of the other enzymes that are targeted by ibrutinib. And you ask, why do you need to develop these? Well, it's just similar to the case of CML. I think John Bird's group, along with Ron Levy, had this interesting presentation at the ASH by Court at last year's ASH. And John has made the observation with the members in his group that the ITK may be necessary for antibody-directed NK-mediated ADCC, and he discusses at length. So the question may be, is having many different types of these kinase inhibitors on hand may allow for some sort of selectivity. You might have certain indications where one might be benefiting over the other. And in this case, you have a potential for perhaps less inhibition of this important enzyme. Well, this was studied sort of a multi-center phase 1 study. It was the objective of the study to determine the recommended phase 2 dose, look at the pharmacokinetics, and determine the safety and tolerability and clinical activity. And this study is still ongoing. This was work that was presented at the ASH meeting. This is the study design. Patients received continuous dosing until they reached progressive disease or intolerable toxicity. Eligibility was to have CLL, adequate organ function, as shown here. And the dose escalation scheme was embodied here with QD dosing, and then later on an expansion cohort, which then elicited BID dosing because of some of the data that I'll present. The adverse events, this drug was relatively well tolerated and had similar toxicities you might find with other tyrosine kinase inhibitors, diarrhea being the most prominent, fatigue. A few patients developed thrombocytopenia, neutropenia were seen. Occasional cases of infectious disease that might be related to potentially the disease or the immunosuppressive effect of the drug. But I think the toxicity profile of the drug appears fairly comparable to what you might see with some of these other tyrosine kinase inhibitors. This is the pharmacokinetic measurements, and you can see that with 400 milligram dosing, you can achieve levels. The peak is within an hour or two with oral dosing, and the half-life is relatively short. You can see that there's no accumulation of dose because of its short half-life. So day 15, there's no increase in the relative concentration. And you can see there's relatively some dose dependency in terms of the peak levels. Now, what was interesting is the group, both Avella and now Celgene, have been doing receptor occupancy, measuring the level of an enzyme. Here, this is the BTK occupancy. What you'd expect is the small molecules bind BTK and form a covalent bond. And this is what you would anticipate with 100% receptor occupancy at these various doses, starting with the dose of 250 and going all the way up to 1,000 milligrams QD. However, after 24 hours, you could see that there has been some decline in receptor occupancy, arguing that there may be a need for twice daily dosing. This is shown here where you give the drug twice daily, and you can see that there is high receptor occupancy than at the 24-hour time point. So I think that this is certainly an, evidence that would argue in favor of twice daily dosing as opposed to once daily dosing. You can see that the lymph node response is similar. The patients may have reduction in lymphadenopathy with kinetics that may be similar to what has been observed with drugs such as ibrutinib. You can see that at the lower dose ranges, it's a QD dosing, more modest reduction in lymphadenopathy. However, with the BID dosing at 375 or 500, there's a more substantial decrease in lymphadenopathy. This is shown in the waterfall plot. This is the BID dosing, either in red, 375 milligram BID, or the 500 milligram in gold. And this is comparable to giving it at very high concentrations. You can see this effect. So the question is whether giving higher doses may allow for more convenient daily dosing. But I think certainly I think that BID dosing may be necessary. As far as the effect, the inhibition of such receptors as CXCR4, BTK is required for that. You can see increases in lymphocytosis that occurs with similar kinetics as was observed by Bird and others with the ibrutinib. And you can actually see then also this with the higher single-day daily dosing. Now, response rates have, this is still ongoing, but I think with the proper dosing, you're getting respectable response rates. These are all partial remissions. There are no complete remissions. And response rates in the BID dosing range that are bordering on 2/3 to greater in terms of response and heavily. So I think the conclusion here is that the CC292 is well tolerated. It's an oral twice-daily therapy. The administration of CC292 achieved a dose-dependent and rapid high nodal and partial responses in relapse refractory patients, including those of high-risk cytogenetic features, and the results support continued development of this drug for treatment of CLL.